Thank you. So we already known about these trials, so it's not a new trial. The first trial what I'll be discussing is Nivolumab plus Cabozantinib versus Sunitinib for previously untreated renal cell cancer. We already have the initial results published. This is the long-term results of the 55 months follow-up of the CheckMate9ER. So we all know the CheckMate9ER stratification. So previously untreated metastatic clear cell RCC were randomized between Nivo Cabo and Sunitinib. And the primary endpoint was progression-free survival, and secondary endpoint was overall survival, response rates, and progression-free survival was superior in the Nivo Cabo arm and compared to Sunitinib for 16 months versus 8 months, and the OS was also superior between Nivo Cabo and Sunitinib. Nivo Cabo was superior 46 months versus 36 months. And when we look at the overall response rate, there is approximately 55% overall response rate in the Nivo Cabo arm, whereas Sutent was 27% response rate. The complete response rate was 13% and 4%. But as we had previously discussed, the prior discussion as well, when we look at the favorable risk population, the median PFS was better with Nivo Cabo. It was 21 versus 12 months. Whereas if you look at the overall survival data, the long-term data, it was not statistically significant, but Sunitinib had actually a numerically higher overall survival compared to Nivolumab Cabozantinib in the favorable risk population. Whereas when you look at the intermediate risk and the poor risk population, it was clearly favoring the Nivolumab and the Cabozantinib arm. So the PFS in the intermediate to the poor risk was 15 versus 7 months, and the OS was definitely superior. It was 43 months versus 29 months. And when we look at the efficacy by the organ of site of metastasis, liver, bone, lung, all favored Nivo Cabo. And the toxicity, I need not talk too much because there are multiple studies we have already known. But what is important is the number of adverse events which led to discontinuation of Nivolumab and Cabozantinib was 28%, whereas it was 10% in Sunitinib. So Nivolumab and Cabozantinib is not actually much well tolerated compared to Sutent. And subsequent therapies, both of them received subsequent therapies. For patients who received Sunitinib, around 50% of them received subsequent PD-L1 inhibitors, so that is well matched. So there's nothing new we learned from the updated analysis, that it continues to show improvement in progression-free survival and the overall survival, whereas the overall survival for the favorable risk seems to be not that great with the favorable risk. So we might consider Sunitinib also for favorable risk population. Coming to the second talk, this IOIO trial, that is NIVO+IPI versus Sunitinib. Again, the long-term data published, 80 months follow-up. We know the trial design, which was NIVO+IPI into 4 doses followed by Nivolumab maintenance, whereas the other arm was Sunitinib. The primary endpoints was overall response rate, progression-free survival, and OS. And second, in the poor, intermediate and poor risk population, whereas the secondary endpoint was the same, but in all patients. And the exploratory endpoint wasn't the same in the favorable risk population. So when we look at the intermediate or poor risk group, the median progression-free survival was significantly better, just 12 months versus 8 months. Whereas again, for the favorable risk, the progression-free survival was not actually superior. It is actually crossing the 1 point. So hazard is actually crossing. When you look at the OS data, from the intention to treat analysis, if you include all the patients, it is better. It is 52 months versus 37 months. Whereas if you split intermediate risk, poor risk, and the favorable risk, the intermediate poor risk continued to show favorable OS data. Whereas for the favorable risk, actually the Sutent again showed a better overall survival compared to the IP-Nivo. So when we look at the site of metastasis and we sub-classify further, patients who had only lung metastasis seem to do better with ipi-nivo combination, whereas those who had liver and bone, I did not show significant improvement. But again, this is an extrapolatory subgroup analysis. And the incidence of grade 3 or grade 4 adverse events remains largely unchanged. It only had expected side effects. The response rates by ITT was higher in ipi-nivo, 66% versus 53%. And probably this is what is a game changer. The complete response rate in the ipi-nivo arm was 27%, whereas it was only 9%, the Sutent arm. So the investigator conclusion, ipi-nivo showed an improvement in long-term survival and showed durable response rates compared to sunitinib in the intention to treat and the intermediate and poor risk group. The complete response rate and median duration of response was better in the dual IO arm, regardless of the IMDC risk subgroup, and in long-term survivors, and there were no new safety signals which emerged from this. That I conclude.